you should understand it very well, okay? And not only for now, it is going to be something you're going to use all your life, okay? And as time goes, we go to understand antibiotics much better. And it is not something that is a one-time process. It's a process that you probably will throughout life keep learning about. There will be new antibiotics coming, there will be new understandings, there will be few things that we'll understand. Over a period of time, we keep on learning these things, okay? But the general principles would probably remain the same. General principles of an antibiotic will remain the same. We've got a huge lot of antibiotics that we have. We've got classes and classes of antibiotics. The incidence of these resistant organisms are going to keep on increasing. It's not going to reduce in any way. It is not going to reduce in resistant organisms are going to increase. Like we had the active example of a young girl who was admitted to the hospital, and that really opened my eyes. I was really shocked to see that we had a patient who had a carbapenem resistant enterobacteriaceae that came in from the community. It is extremely scary to see something like that, because this means like it's COVID everywhere. You get an infection and there's a possibility of you landing on a ventilator. It's crazy. It's literally crazy. She was in our hospital, she got saved. Okay, the other guy on the other side, he is also a young guy. And if that guy also shows carbapenem resistant enterobacteriaceae, I would be again shocked. And then probably I already presented the case on another platform because I was shocked to see that. Okay, all right. So what is the definition of a multi-drug resistant organism? What do you understand by MDRO? What is this? What is MDRO?
Resistant more than
more than
two.
So resist one antibiotic from three classes. One antibiotic from three classes. So say you have aminoglycoside, you have quinolone, and you have beta-lactam. Okay, there are so many classes, right? So you have aminoglycoside, for example, you have quinolone, and you have say beta-lactam. So say ceftriaxone here, resistant, levofloxacin resistant, and gentamicin resistant. So three class ho gaya. Since it's resistant to three classes, this will be called as multi-drug resistant organisms. If I'm going fast, stop me because you need to understand this properly. Okay. So any patient that comes in and you find three classes of antibiotics. So when you look at the antibiogram, you just look at RS resistant and all. You look at the classes. Which class is this? Okay, the beta-lactam cefazolin is resistant. Even if there is ceftriaxone, cefazolin, all these things, but one of the beta-lactam antibiotic is resistant. One of the beta-lactam antibiotic is resistant. Plus one from another class is resistant. From a third class is resistant. Say monobactam, astronam that is resistant. 3. It is called as MDR. The only bug that is MDR but resistant only to one class, which is that one. There's only one bug, there's only one bacteria that we will call as multi-drug resistant, even though it is only sensitive to one. Which is the one? No? Staph aureus, MRSA. So when you say MRSA, it is resistant to methicillin. Methicillin resistant Staphylococcus aureus. But this is grouped in the MDRO. This is grouped in the multi-drug resistant organism. Right? Because it is known to spread, it is easily available, nosocomial infection, that's why it's called as MR. It is grouped in that classification for MDR. The other category is XDR. Now what is XDRO? What is this? When I say XDRO means there are only less than or equal to two classes, less than equal to only two classes, or less than two classes that are sensitive. So you have oxazolidinons, you have monobactams, you have beta-lactams, you have glycopeptides, you have aminoglycosides, there are quinolones, there are so many classes, but only one or maximum two classes are sensitive. Baki sab resistant hai. It is called as XDR. For example, carbapenem resistant enterobacteriaceae. When I say enterobacteriaceae, looking at Klebsiella, Pseudomonas, E. coli. That's what we're looking at when we say CRE. Carbapenem resistant Enterobacter C. Klebsiella pseudomonas E. coli, all that comes in there. Enterobacter species comes in there. Clear? Huh? So when I'm saying this, what is happening? CRE, it may be sensitive to colistin. You understand? It may be sensitive to colistin. So there is one class of antibiotic against which it is only one class of antibiotic against which it is sensitive. This particular organism. That's why a CRE will feature as XDR. Clear? But if this CRE was sensitive to levoflox as well as say aztreonam, will this be called as XDR? No, it won't be. Because there are three classes now of antibiotics against which the organism is sensitive. Clear? There is another class called as PDR. What is PDR? Pan drug resistant. Okay, that means there is no antibiotic against which this will probably work. No antibiotic which will work against this particular bug. Clear? So you should know these terminologies because it is in these that you really want to use your antibiotic principles and knowledge about antibiotics. You're going to use in these your antibiotic principles and knowledge about antibiotics. You're understanding? Sada, I feel, in my personal opinion, a normal infection does not require an antibiotic also because you are very strong yourself. You don't require anything. You understand? So, but when it goes beyond normal, that is when you require an antibiotic. You know? So, similarly, when this is not beyond, this is much beyond normal. This is much beyond normal where you need to understand how to use that antibiotic well. How to use that antibiotic well. You're understanding? How do these become resistant? So she had a very wonderful slide. How do they become resistant? So they become resistant by various mechanisms. Okay. Now one of the resistance mechanisms is by creating enzymes against the particular bug. Okay. For example, there is a bug. Okay, there is a bug. There is an antibiotic. There is an antibiotic. There is a bug. There is an antibiotic. Now say the antibiotic is beta-lactam. Okay. Now what does this bug do? This bug creates a beta-lactamase. Okay. Now because of this, what is happening? This bug is resistant to this beta-lactam because the moment you give an beta-lactam, this will get destroyed because of the beta-lactamase. Clear? You're understanding this much? It gets destroyed because of the beta-lactamase. This antibiotic gets destroyed. So, if you have a bug that harbors a beta, like for example, which is a beta-lactamase cephalosporinase. So, you have ceftriaxone as a molecule, and this organism harbors cephalosporinase. Okay, this means तुम कितना भी ceftriaxone दो, कितना भी दो, उसको डोज बढ़ा दो, prolonged infusion करो, क्या करना है कर लो. Beta-lactamase is going to destroy the ceftriaxone. The ceftriaxone is not going to be effective for this bug. Okay, so amoxicillin, for example, is not going to be responsible. So how do we get around this? We get around this by actually putting some drug along with this amoxicillin to inactivate cephalosporin. Okay, and that is called as beta-lactamase inhibitor, BLI. You understand? And that's what amoxicillin clavulanic acid is. The clavulanic acid is a BLI which inhibits the beta-lactamase enzyme, and thus the amoxicillin can work. Understand? Simple. BLBLI. That's what we call BLBLI. Where other examples of the same thing that we use regularly is piperacillin, tazobactam. Cephalosporin, sulbactam. So this is BLBLI. Clear? So this is one mechanism in which it kind of works. It works. Now this per se, this is the commonest mechanism for any antibiotic to become resistant to a certain organism or organism getting more resistant is the commonest mechanism is the production of these kind of enzymes. This is commonest. Apart from this, there are other ways. And one of the other ways, all these bugs, for it to get in, it needs to have a channel or it needs to have a binding site. Either the antibiotic should go and attract on a binding site, which is classical for penicillin group of antibiotics, okay, where it comes and gets binded over here and then exerts its action. Or the other way is it actually moves inside this and creates the problem. It moves inside, creates the problem. This is porin channel. Okay, so certain bugs like Pseudomonas, they have a mechanism in which they alter these porin channels. In fact, throws the antibiotic out by another pump that it has inside called as efflux pumps. So like Pseudomonas becomes a big problem. Why? Because it has got efflux pumps mechanism where the antibiotic will get it but it will throw it out. So that is one mechanism, efflux pump. Right? Clear? There are bugs which have altered binding mechanisms. That is, penicillin binding proteins are altered. When they are altered, this antibiotic cannot come and sit on it. So it will not work. So altered binding penicillin binding proteins will also cause resistance mechanisms, whereas efflux pumps is the other one, and alteration of the porin channels is the third one. Right? So these are the various resistance mechanisms. Now you have heard from our Carba R certain names like NDM, like Oxa. What is that? What is all that? वो क्या है? What is that? So exactly. So where does it figure here? No. So that is all from this class. That is all from this class. Okay. So this all comes from this class. Now let me explain to you how this is. Okay. Do you understand this much? Now we are going into something called as what is all this NDM and all these things. Okay. So all these beta lactamases, all these mechanisms are classified by something called as the Ambler class. Ambler classification. It's called as Ambler classification. Okay. Now what is the Ambler classification? The Ambler classification divides these there are many, okay, divides these resistance mechanisms, so that we just now discussed, into 4 classes: A, B, C, and D. Clear? It divides them into 4. This is fine only?
Yes, sir.
You all So that's what evolution of life is all about, right? We get stronger by mutation, we get stronger by learning, we have got stronger from cave age to now. So we got stronger, right? Similarly, they also have the principle of Darwin's theory, right? They will keep on mutating. It is something that's evolution. We saw the virus getting stronger and then we getting stronger than the virus, isn't it? COVID, did we see that? We saw it, right? We saw it very clearly. It was history in the making for us. We saw the virus almost killing us. And then over a period of time, we got stronger to them. Now we are stronger. Now an XBP variant comes along, it's COVID, it's fine. Initially it was COVID, means we were all in 5 clothes. Isn't it? They get stronger, they learn. Okay, they have genes. Those genes are responsible for mutating. They have chromosomal mutations. They have all these things that they create. That's why, that is the reason we are saying don't misuse the antibiotic. Because every time you put an antibiotic, you are creating a collateral damage if it's not required. How does it create collateral damage? For example, today I have a viral fever. If I have viral fever and then I decide, okay, I have a viral fever, let me just take an antibiotic. I take an antibiotic. I have a viral fever. I don't require the antibiotic. What happens to my body? My body realizes, what is this? I don't require this. What does the body do? It excretes this in the urine, in the stool. Where does this go? This goes into our groundwater. Okay, it goes into our groundwater and then the purified form comes back to you. But now what has happened? Sublethal concentrations of the antibiotics have entered into the groundwater. Okay, the bacteria that is there is now getting sensitized. Okay, the bacteria are now understanding that there is something like this and how to fight against it. And then that same bacteria gets back into our circulation through outside source, which is more stronger than otherwise. That's collateral damage. Okay, so that's why we don't want to use antibiotics if it's not required. It's as simple as that. Okay, huh? So now we come back to the another classification, which is A, B, C, and D. Okay, you have to remember this. Okay, now class A is called as serine group. What is it called as? Serine group. Okay, clear on this? Class B is called as a metallo group. Okay, this is also called as serine group. So you have three classes: serine, metallo, C, and serine group. Okay, the serine group are the ones that we call as KPC, SHV. Okay, sorry, Klebsiella, SHV, and TEM. These are all enzymes. These are all small enzymes. There are multiple enzymes of class A. Okay, multiple enzymes. Okay, SHV, TEM. These are all like beta lactamase producing organism, the ESBLs. That's what we discussed. This is the ESBL. Clear? Clear on this? That means Klebsiella produces a enzyme which can be labeled as SHV or TEM. The name of the enzyme is SHV or TEM. Actually, these names have come from like for example, TEM is Temolina. It's a sister from whom they discovered this. It's a nurse by the name of Temolina, and through her they found that there is a beta lactamase enzyme in the bacteria from that female, and they found that this is beta lactamase. And if you want to now treat something from you need a beta lactamase inhibitor against TEM and SHV. You understand? So there is a whole lot, but this is the striking example. Clear? Class A, ESBL, extended spectrum beta lactamase. Spectrum is larger. Okay, right? Then class C is something called as, remember, I'm just showing it so that you can remember. Okay, class C is ANC. ANC. It's a certain chromosomal mechanism that inactivates a certain beta lactamase that inactivates. Okay, this is usually seen in the spices group. SPICES, Serratia, Proteus, all these things. Okay, it is there in these kind of organisms. The spices group is called. Okay, in that group you see all this this kind of AMCs. Clear? AMC. Clear on the AMC? This is a kind of kind of resistance mechanism. This is again a resistance mechanism. Clear? So we will not go into inducibility of MC and what it is and how to tackle all these things. But MC. Okay. The other one is metallo. No, metallo beta lactamase. B. Metallo beta lactamase. This is your famous NDM. New Delhi metallo beta lactamase. Okay. So this has got a metallic ion that is there, a zinc ion or something like that. That ion that chelates and prevents and does not allow the antibiotic use. It's another kind of a mechanism. All these are beta lactamase. So this is New Delhi metallo beta lactamase. You understand? Clear? Metallo. So this is KPC. Okay, this is KPC. This whole group is SHV, TEM, KPC. This whole group is NDM, IMP, VIM. These are the commonest ones we are seeing. There may be more. These are the commonest ones we are seeing. NDM, IMP, VIM. Just like I said, the names of enzymes. These are names of enzymes. Imipenamases. Okay, Verana integrated something it is called as. Okay, Verana integrated metallo beta lactamase it is called. This is New Delhi metallo beta lactamase. This is imipenamases. You understand? So these are all metallo beta lactamase parts. Okay, and then in the class D you have OXA group. You hear OXA 48, OXA 181. You heard those names, right? OXA. There are whole lot of OXA. If it's 181, you can imagine how many are there. You understand now? Clear? In our Karbar, we are not finding the whole lot. What we are trying to figure out, we are only able to get KPC, we are only able to get this group, and we are only able to get this group. The rest we are not seeing. We are not seeing MC, we are not seeing SHBTEM, we are not seeing all these things. You are understanding? So the carba R is only giving you the beta lactamase producing enzymes and will help you to distinguish between classes. Class A, class B, class C and class D. Clear? Are you understanding? Clear? Because I know that certain classes will not respond. For example, this class will not respond to a carbapenem. It will not respond only. Huh? You understand? This class will not respond only to a carbapenem because it is NDM. NDMs don't respond to carbapenems by definition. Right? We know that this group SHVTEM will easily respond to a carbapenem. You understand? It will easily respond to a carbapenem, this SHV and TEM. I know that this particular thing can also be resistant to carbapenems. I will need something else over here. Are you understanding? I will need something else over here. Because why are we talking carbapenem? Because ESBL has to be treated with a carbapenem. By definition, the mortality is much lower when you treat an ESBL with a carbapenem. Are you understanding? That is why we are comparing to carbapenem. कि क्या करना है? अगर नहीं काम करे तो क्या करें हम? ठीक है? Clear on this? I hope you've understood this. A, B, C, and D. Okay, Ambler class. A is SHV, TEM, classical enzymes. B is metallo-beta lactamase, which the classical is NDM, IMP, VIM. C is AMC, and D is OXA48 and 181. Clear? These are the classical group of enzymes that we have. We are doing the carba only to find out some of these: NDM, OXA, KPC. You can't have the whole set coming in. Are you understanding? And this is only the Ambler classification for lactamases, beta lactamases. Right? Apart from that, there are other resistance mechanisms. Okay? And why? So that means to say these are the reasons why the antibiotics will not work. These are the reasons that if you now use a piperacillin on a patient who is having this, will it work? It is not going to work. If you have a patient on Magnexport and you're going to use this, it's going to work, it's not going to work. Whereas OXA48 may singularly work Magnexport, OXA group may singularly work, but if you have a combination, will it work? It will not work again. That's why we want to know what are we doing. What are we doing in the ICU with the bugs? And these are the resistance mechanisms. But one of the reasons why antibiotics don't work, is because of us. And what is that? Because why the antibiotics don't work is we have a wrong diagnosis. This is one of the main things that causes antibiotics not to work. For example, you have a patient that is in the ward was not okay. They put the patient on a Foley's catheter, brought the patient down to the ICU. Okay, now this because the patient was not well and patient had a fever and was not doing well, patient was shifted from ward to the ICU. And what did you do? You saw the patient and you sent a urine culture. Now any patient who has a catheter will have urine culture to be positive. Any patient that has a catheter, will have a urine culture that is positive. And now what happens? You send a urine culture and the urine culture grows E. coli which is sensitive to aminoglycoside. And you say, I start the patient on gentamicin. Okay, which is a good antibiotic for the urinary tract. But this patient doesn't improve. Why? Because your diagnosis is not UTI. Your diagnosis is something else. It might be a typhlitis, it might be an abdominal infection, it might be a respiratory tract infection, but it's not a UTI. You understanding? So a wrong diagnosis is one of the failures of when you are actually treating, why the treatment is failing. The second is the wrong application of pharmacodynamics. Let me give you an example of this. You have a patient who has septicemia. Okay, you have a patient who's got a respiratory tract infection. Okay, you do a culture. You do a respiratory tract infection, and you do a culture. You do a ball. In the ball, you actually grew MRSA. In the bar you grow MRSA, and you know that the most active antibiotic against MRSA is daptomycin. It's one of the very active antibiotic, daptomycin. Unfortunately, this patient does not improve. Why will the patient not improve? Because daptomycin is inactivated in the lung by surfactant. It is inactivated in the lung by surfactant. So what is going to happen? How much of daptomycin you are going to give? It is not going to work because it is not going to enter the lung. So you have wrong application of pharmacodynamics. Are you understanding? Huh? So wrong diagnosis, wrong application of pharmacodynamics. The third is wrong dosing. Wrong dosing. Now how will wrong dosing affect? That is what when Supriya started the lecture talked about altered dynamics in critically ill patient. Okay, so critically ill, all these antibiotics that we are giving, when you open up the package insert, how is that dose formed? That dose is formed after testing it in healthy volunteers. What do? They keep the person over there, they inject the drug. These are there, it is done everywhere. It is done if you go, there is a lab in Pune, there is a lab outside at Navi Mumbai where they do all these things. These pharma companies, they inject and they find serum levels. So it's healthy volunteers. That's why you get those doses, right? However, what doses we are going to use is not in healthy volunteers, it's in actually disease subjects who have got altered critical status. You understand? Altered dynamics. So that's why you need to understand the dynamics or what happens in critically ill patient so that you avoid this problem of wrong dose. Clear? Clear? So that's why we need to understand pharmacokinetics. We need to understand pharmacokinetics and pharmacodynamics. And when we say pharmacokinetics and pharmacodynamics, it means what the drug is doing to the body and what is the body doing to the drug. It's as simple as that. And that's why we are now going to discuss PK and PD of these particular antibiotics. Understood till now? Any doubts? Any doubts till now? Any doubts?
So in that Carva R, what? Actually, I don't know what actually we test for. Is it resistance or is it sensitivity?
Carva R? No. Carva R is, what is Carva R? Any idea? Anyone? You're doing Carva R. Anyone? So we want to detect a gene. Nothing else we are doing. So we will only detect this, what is the gene. So we are doing Carva R, you should know what you are doing. Okay, so if you have an isolate, say I have an isolate, it is Pseudomonas. Now that Pseudomonas, I am not doing sensitivity, we'll come to that now, okay? But what we are doing over there, you will be finding out this Pseudomonas mein kaun sa gene hai. It is not telling me about efflux pumps, it is not telling me about pooling channel, it is not telling me about penicillin binding proteins. All that it is telling me is there this particular gene, genetic mechanism, which is from the Ambler class A, B, C and D. So that's why it checks only those 5 genes. There are multiple genes, but it checks only those. So it gives you an idea कि अरे इसमें तो ये है, I cannot keep piperacillin, I want to give meropenem. Immediately, it will not take you more than 2.5 hours to get a report from a Carva. It is just finding out the genetic mechanism. Clear? Any doubts? So if you don't know, ask like how Supriya asked. Okay, then you will understand properly. Otherwise, you will be just again in empty space. You will do for anyone, any bug, no. I can do it for anything. Any gram-negative organism, because this is gram-negative. Gram-positive, you get methicillin. This is not there here. Carva doesn't test for that. Carva is testing only for KPC, NDA, OXA48, IMP. You are understanding? It is not testing for anything else. It is not testing. That's why if you look at the report, it will show you those 5 things. You are understanding? It is only going to show the resistance mechanism that is part of this beta-lactamase Ambler classification. It is not going to show you anything else. Among all that is why we started by saying there are so many ways a bug can get resistant. There are so many ways. There is outer membrane pooling channel changing, there is efflux pumps, there is penicillin binding protein changing, and the last one is beta-lactamase. Extended spectrum beta-lactamase productions. Clear? So it is only testing that arm of it. So any bacteria, let it be Pseudomonas, let it be any gram-negative, Klebsiella, let it be anything. You can test any bacteria if you are suspecting that this bug is MDR. Clear? You can test any bacteria if you want to figure out whether there is MDR organism or not. समझ में आ रहा है? Clear? Concept is clear? Concept is clear? Huh?
But sir, sometimes you say that carbar is not needed. So how do you judge about it?
Because you have the susceptibility pattern. If you have the susceptibility pattern already that says it is sensitive to this, I don't need the carbar. This is one step prior. Are you understanding? So for example, when will I use the carbar? The question is that, right? You're asking me that. So I have a patient who is on a certain antibiotic, and I've done everything possible to optimize that particular patient's antibiotic schedule. Okay, I've done everything possible to optimize. I've done optimal source control. I've done everything, but this patient is not improving. So there is a possibility that there may be combined resistance mechanisms, and my one antibiotic may not work. And because there are two, maybe there's NDM plus OXA48, I need to add a combination of antibiotics to supersede that particular resistance mechanism. Or for that matter, I have a patient who is alarmingly ill, a patient who is of febrile neutropenia, who has WBC counts that are very low. Okay, now these patients, I can't have time, I don't have time here. Now I grow something, I have to first grow, I cannot just send carbar. I have to grow something. It may be gram-negative bacillus that is growing. I grow gram-negative, patient is very sick, I need to know quickly whether my antibiotics are right or wrong. Okay, or kind of an idea whether my antibiotics are okay or not. So the moment I grow something, I send it for carbar, the gene will, because it's grown, there will be a gene, right? So because it's grown, there will be a gene, that means isolate. It's grown. I'll do a gene. In the gene, whatever the bug may be, is gram-negative, whatever the bug may be, now I know that this probably is NDM. So I'll say, oh, this is NDM, we need to add something like a monobacterium like Astionam or something like that onto this. Are you understanding? And then I will wait for the rest of the reports to come in. But at least I am getting a direction that I am okay. If I just kept the patient on Emberopenem, this patient would have died.
Yes, sir.
This patient would have died because it's febrile neutropenia. He is dying every hour, isn't it? Huh? So I want to narrow my antibiotic to a spectrum to a certain antibiotic where I feel this will probably work. Then I'm going to use my carbar there. You're understanding? Huh? So the moment I get a phone call and I have a patient that is on the ventilator not doing well, I got a phone call, gram-negative isolate. You can think, should I send a carbar because this patient is not improving? Other way around. You have a patient who is on the ventilator, you have sent off investigations, patient is improving, patient is doing well. Okay, I have the time, let me wait. You understand? Let me wait for the sensitivity because that is going to take time. For the sensitivity report to come back, it is going to take another 2.5 to 3 days more. You understand? Here I already get a resistance mechanism. Are you understanding?
Yes.
And that will help me to further understand what treatment, whether it is right, wrong, or should I change anything. Are you understanding now?
Yes, sir.
Understanding?
Yes.
Clear, Elizabeth? Did you understand or not?
Yeah, I
Any questions? Tell me. Tell me.
Pesticides and pseudomonas, they have like multiple other mechanisms. So,
We don't know how to test them. That is why clinical, na? That is why clinically you have to be strong. It's not just, these are only things that are helping us. At the end, this you have to use for your judgment or your clinical practice. Say I have a patient on pseudomonas and that pseudomonas had NDM positive or whatever, has got OXA positive. Okay, and still the patient is not improving. Now I will think probably it is altered porin channels or an efflux mechanism that's working. I will want to now reduce the efflux, how by doing alteration of my pharmacokinetics and pharmacodynamics, which will come to now. You understand? समझ में आ रहा है? So that comes to the question. Now that we understand wrong diagnosis, we understand all these things, and now we come to the altered dynamics that happens in critical care, which is very different from what is normally occurring. Very different from what is normally occurring. Now, what is so much different? Okay. So, you must understand certain concepts. The first concept we're talking about is volume of distribution. Now, what is this, and how does this matter to us? How do you think this matters to us? See, you can answer these questions here, okay? You can make how much of mistakes you want. No doubt is silly. Every doubt is going to help everybody else. Okay, no doubt is silly. You want to ask 100 doubts, you ask 100 doubts. I am there to solve it. Okay, but no doubt is silly because it helps everybody else. Everybody will have the same doubt, only they will not be telling. You understand? So, what is volume of distribution and what do you feel this makes a difference? So, I'll explain to you. Now, volume of distribution is the volume into which the drug goes. Volume of distribution is the volume in which the drug goes. So, if I have X volume and I say this is optimal for this particular drug, Okay, and now increase this volume. Obviously, the drug will get diluted. Obviously, the drug will get diluted. Understanding? The drug is going to get diluted here. If the drug gets diluted, obviously, whatever we have discussed about how much concentration should go in and what is going to happen, everything will be diluted. You understand? And if everything gets diluted, this particular drug may not work only. Are you understanding? Huh? Clear on this? So, in critically ill patient, what really occurs is that when a patient comes in from home to you in an intensive situation where blood pressures are low, not okay, all these things are happening, what do you do normally? You resuscitate. You understand? You resuscitate them. And when you resuscitate, what are you doing? You are actually giving loads of volume. Loads of volume. Okay, loads of volume. So 2 liters. For example, the extracellular fluid normally, what is the extracellular fluid in your body? 0.4 liters per kilogram. This is your extracellular fluid in your body. 0.4 liters per kilogram is what you have inside your body as ECF. Okay. Now 0.4 liter per kilogram means कितना liter हो गया? 0.4 into 60. 0.4 into 50 is
2 liters.
2 liters. This is what you have inside your body. On top of it, you put 2 liters more. At the resuscitation, 2 liters, no? 1.5 to 2 liters is what you are giving. What has happened to the ECF? I'm not even gone to the rest part of that. I'm just telling you about just resuscitation. In just resuscitation, what has happened? You have diluted the drug 50%. समझ में आ रहा है? Clear on this? So that means to say, my volume of distribution is becoming big. Right? The second thing also what is occurring in these cases is, how do you normally, when your blood pressure drops, what does your body do? When your blood pressure drops, what does your body do? That's fine, but how does it compensate for the volume? What it does is, you have, apart from your body, on your cell, you have an endothelium which is called as a glycocalyx. Endothelial glycocalyx. What happens is, the moment you start dropping your blood pressure, your interstitium actually throws water inside, which is a large compartment. You understand? Huh? It throws a larger amount. Not only that, water also leaks from here everywhere. Both the things are occurring. There is increased permeability and capillary leak, and at the same time there is interstitium that is also leaking outside everywhere. You're understanding? This is also leaking outside everywhere. Clear on this? So what is effectively happening? Again, your volume of distribution is going higher. The water was actually in the interstitium. Where it is going? Everywhere else. You understand? So again, what is happening? Your volume of distribution is going much higher. Clear? You've understood this? This concept of understood? So the volume of distribution in a critically ill patient is increased, like majorly increased, like crazily increased. You must understand this very carefully, very clearly. You must understand this. Okay? And so the existing antibiotic will not work adequately. Such is your understanding? It's but obvious it will not work. That is why what we want to give our patients? Loading doses. Clear? So now you tell me, if you have a patient in the ICU and you are not going to give a loading dose, are you doing the right thing? Absolutely wrong thing. That's why you need a loading dose of an antibiotic. Right? Clear? Shanti Suvarna, we had this patient over there. Loading dose was supposed to be given, not given. Why? Patient just shipped to Dr. Talwalkar, not given. Why? Should be given? No. Clear on this? Loading dose volume distribution. So now this is not the only part of the story. You know the volume distribution is elevated. Now, a few things more about the specifics of the antibiotic that you are going to use now. I told you, you need to understand the antibiotics now to actually dose this better. It's not just simple, just increase the loading dose. You must also understand. For example, you have a patient who's got bacteremic sepsis. When you say bacteremic sepsis, what is happening? The bacteria is where? In the blood, in the extracellular fluid. Right? It is in the extracellular fluid. Clear? Now in this patient, if I now give tigecycline, it will not work, and I'll explain to you why. Okay, so you have, what you must understand now here, if the volume of every drug, if you open the package insert, it will be written BD. There it will be written VD there. It actually tells you the volume of distribution. So if it is less than 0.3 liters a kilogram, if it is less than 0.3 liters per kilogram, this will largely be in the extracellular fluid. This antibiotic will largely be where?
Extracellular.
It will be in the extracellular fluid. Clear on this? Clear? You understood this much? On the package insert of every antibiotic has got a volume of distribution. It has got what? A volume of distribution. Clear? If the volume of distribution in that package is written as less than 0.3 liters per kilogram, this antibiotic will remain in the extracellular fluid. Means it will not go from here into the tissue. It will remain right inside the blood.
No distribution.
You understand? It will remain right inside the blood. So there are certain antibiotics, for example, daptomycin. What does daptomycin do? It remains in the blood. And that is why it is a fantastic drug for bacteremic sepsis. When there is bacteremia. Clear? You understand? So that's why you need to understand volume of distribution. Clear on this? Aminoglycosides. Fantastic drug because the volume of distribution is very low. So if it's a patient of empirical sepsis and empirical antibiotic I want to give, I don't know, and I think it is bacteremic sepsis, that is bacteremia, is so sick that is bacteremia, I would want to use these drugs. Are you understanding? Clear on this? Understood volume of distribution concept? Now, there are certain antibiotics that have got a volume of distribution more than 0.7 to 1 liter per kilogram. What is the meaning of this? What do you think is the meaning of this? Ashok? This was only ECF. This is everything apart from ECF.
Means bacteria.
The bug, the antibiotic.
May spread out extra.
The antibiotic will. This is all about antibiotic. So the antibiotic, if the volume distribution is high, it will spread from the blood outside. So it will not work inside the blood. It will work
So
in the.
it can work inside also, outside also.
It will not, because volume distribution is so high that blood से बाहर निकल जाता है जल्दी से. You understand? So this will go out of the blood, but it will go where? Inside the tissues. It will go inside the tissues. Where it will go? Inside the tissues. It will go inside the tissues. So drugs like TK cycline. That is why for skin and soft tissue infections, tigecycline is the drug of choice. Why? Because it needs high concentration in the skin and soft tissue. Clear on this?
They give that dalacin also clean now.
So let's come to that. Okay? Clear on this till now? So can you use tigecycline when the patient has got bacteremia? No. Why you can't use it? Because tigecycline has got a very high volume of distribution. It will immediately go into the tissues, and that is why I want to use tigecycline only when there is skin and soft tissue infections. Clear? Clear on this? Clear? Like in abdominal sepsis. In abdominal sepsis, I want it to enter the tissue. I'll use tigecycline. Are you understanding? But I will not use it when there is bacteremia. Clear? One corollary to that is, if there is tissue with bacteremia, I may want to use higher doses. If there is tissue spread with bacteremia, like for example, very bad necrotizing fasciitis with bacteremic spread, I will use it but at a higher dose. Because I want both the effects. Clear? Clear on this? Clear? Any doubts? Now, there is another class that comes between this 0.3 to 0.7. This has got the effect of both. It has got a situation where some amount of them is there in the blood, some amount of them is going to the tissues. It's not completely for bacteria. It's not complete. It's not bacteremia. It's not completely for the tissues. It's kind of both. And this is where you have drugs like clindamycin. You have drugs like clindamycin. You have drugs like doxycycline that works. This is where these particular antibiotics work. These are just representatives of those particular classes. Clear? Understood this? So in the catch, this question is so important because when you are actually giving your practical exams or giving your theory exams, this can be an obvious question that can be asked to you. You have a patient who is in bacteremia, will you use tigecycline? This is a very obvious question that is asked in the exams, okay? And then you have to say, no, we can't use it because tigecycline has got a very large volume of distribution. It will go into the tissues and not work in bacteremic spread. This you should know. This you should know because it is something that is going to be life and death. If you're going to give a patient of bacteremia or tigecycline because it's sensitive, because in your antibiotic susceptible pattern, it will come as sensitive. It will come in your antibiogram, it will come tigecycline sensitive. But your source from where you're taking it is from the blood. If you're taking it from the blood, though it is sensitive, I will not use tigecycline because it is from the blood. Are you understanding? Other way around, if I have tigecycline sensitive, it is from the tissue, I'll use tigecycline. Are you understanding? Any doubts on volume of distribution? Any doubts? Any doubts? This is there, this pattern is there on the package insert. So next time we will start reading the package insert. We will per se will not be knowing all the volume of distributions. Okay, some drugs you need to understand which are the ones that have this volume of distribution, these particular drugs, but the rest you may not know. So you can actually look at it. It is written in the package insert.
But
Clear?
with that volume of distribution, we can know where to use.
Exactly, that's what I'm trying to tell you. No, by looking at that, we know. Okay, like for example, you see tigecycline, you'll see, array, its concentration is 1 liter, is 70 liters, something like that. So where are you going to use? You're going to use in tissue. You will be very clear about it. You don't need to know all of them. You don't need to open all package inserts. You need to have a rough idea why this is going to be here, this is going to be here, this is going to be here. These are the major drugs that you use. How many drugs do you use? 10 drugs do you use. Yeah? Those 10 drugs will you require. You don't require the rest. You don't require nafcillin and all. You don't want it, you don't use it. It's there in theory, but you don't use it. Are you understanding? Clear? Clear about volume distribution? Okay. So one of the pharmacokinetic parameters we have understood. That is volume of distribution. Let's go to the other one. Okay. So this was one.
In terms of CKD patient, what is the volume distribution?
Volume is there in your body, no? So even if it's CKD, volume is there in your body. This is where the drug is going. This is where the drug is going. Agar there are CKD patient hai, if your volume of distribution is small, it is going to remain in the blood. Are you understanding? If your volume of distribution is going to be high, it is going to be outside the blood. Simple. So it doesn't make a difference as to what patient profile you are having, if you know what you are talking about. So if you have a patient who is having a skin and soft tissue infection, I will use tigecycline. But if the same patient of CKD is having a bacteremia, I will use daptomycin. I will not use tigecycline. You are understanding? What difference? There is no difference. So if you want to know the difference, where you have to go is to the clearance. So that's the next one. Clearance.
So you mentioned about loading dose.
Ah.
So this volume of distribution, so you said they are found out in normal healthy
Yeah.
individuals. So then
That's why we want larger doses.
so you have to.
Yes, you have to.
For all
Critically ill patients. We are talking specifically of critically ill patients and what happens to them. So it's not only the volume of distribution, you also need to understand how the drug is going. So if you have a patient who is having a bacteremia, I cannot give tigecycline loading dose and expect that it is going to improve. It is not still, because the volume of distribution of tigecycline is not that it goes into the blood. Are you understanding? Are you understanding what I am saying? You need to know everything. And all these are just guidances that gives you an idea of what is happening, how it is happening. Clear? the next thing that we were talking about is clearance. Now, what is the difference in clearance in now Sachin sitting here and clearance in a critically ill patient? What can be the difference? So here the difference is usually the younger critically ill patients who are not very ill, will have a creatinine clearance that is more than 130. Those in sepsis, those in burns, those are younger individuals. They'll have a creatinine clearance that is going to be more than 130 ml per minute, which is more than normal. Which is more than normal, isn't it? More than 130 ml per minute, more than normal, right? So what happens? This is called as augmented renal clearance. That means those antibiotics will get, most of the antibiotics will get cleared more from the body because of augmented renal clearance. All the more reason to optimize your doses. All the more reason to optimize your doses. Volume of distribution was one part of the story. The second part of the story is augmented renal clearance. Okay, by augmented renal clearance, what is happening? You are giving 2 grams, but maybe 1.5 grams is getting augmented, taken out from the body. Are you understanding? So our critically ill patients have got something called as augmented renal clearance. It is this augmented renal clearance that actually reduces the concentration of your antibiotic just like this. You understand? Because it's clearing. So this is a patho that you see in critically ill patients. Augmented renal clearance. Right? Now here again clearance will also depend on what is the, where is the antibiotic going. We are talking about what the body is doing and what the antibiotic is doing, isn't it? Now here again there is an antibiotic. For example, there are antibiotics that are metabolized by the liver. I'm really not worried about those patient antibiotics because as long as my liver is okay, I will give the doses how much ever I want to give. I will give the kidney functions don't make a difference for me here. So I will not change my doses here. Other way around, if I have a patient who's got a kidney elimination, can you give me examples as to if it's getting eliminated from the kidney? That means I'll have to adjust the dose here. In usual population, I will have to adjust the dose. Loading dose will remain the same, but then subsequent doses to prevent toxicity, it is logical. I'll have to reduce the doses, isn't it? However, if it is getting, what you must know is whether it is getting excreted unchanged or not. What is the meaning of this? They are unchanged or not. Means what is going to happen is it is taking the antibiotic and not metabolizing it. It is just excreting it out. So that means if the infection is in the urinary tract, and my antibiotic is getting excreted out unchanged from the urinary tract, it means my maximum concentration of antibiotic is where? In the urinary tract. That is what you must understand. Okay, so we understand about drug dosing. About if the patient's kidneys are not properly working, we need to reduce the dose. If the patient's liver is not working and the drug is metabolized by the liver, you need to reduce the dose. Right? We understand these two aspects. But what you must also understand is that if the drug is concentrated in the urine, excreted unchanged in the urine, and my urine is also concentrated, okay, that maximum action of the drug will be in the urinary tract. For example, you have a patient who comes with urinary tract infection, and now you have a completely XDR drug. I am explaining to you how I am using my knowledge on this. I am using my knowledge on this for a certain patient. Okay, you have an XDR or maybe a PDR. I have a PDR. I have a pan drug resistant organism in the urinary tract. Alright, now I do my MIC of, I will come to all these things. Okay, can we find it to be resistant to aminoglycoside? I find it resistant to aminoglycoside. Okay, resistant to all because it's pan drug, resistant to all. And that's why resistant to aminoglycoside also. But what we know with aminoglycoside, that this drug is excreted unchanged. This drug is concentrated in the urinary tract. Are you understanding? I know these two things that are occurring and it is not through the liver. So there is a possibility that even though the drug is resistant, I will be able to achieve very high concentrations in the urinary tract and probably solve the problem here. Drugs like aminoglycoside, drugs like phosphomycin. Are you understanding how I am using my knowledge to treat these patients? So that's why you must have this knowledge that says, okay, this I want to give an aminoglycoside. It looks like it is a resistant. We'll come to more about this. Okay, but I still want to use this particular drug. You understand? Huh? Similarly, colistin, a drug that you're using. What is happening with colistin? What is happening with colistin? Colistin is a prodrug. It is available to you as CMS. It's available to you as CMS, colistin methane sulfate. This is what it comes as, CMS. Okay, what happens to colistin methane sulfate? You put it in the body, it gets converted to colistin, which is the active drug molecule. It gets converted to colistin. Colistin is excreted unchanged in the urinary tract. Since colistin is getting unchanged in the urinary tract, my colistin will probably work well in the UTI. Clear? Clear on this? Clear? Any doubts till now? So now we've understood volume of distribution. We've understood some aspects of clearance, augmented renal clearance, and what happens when drugs are concentrated in the urinary tract and why we should probably use it. Huh? You understood this much? Huh? So now another part. What do we do? Volume of distribution, clearance. Huh? Now the last part about this is protein binding. This is the next aspect of it. Now what do you understand with protein binding, and can you give me some conceptual knowledge of what is happening with protein binding and what do you think will probably occur? Anyone? Come on. You can make you should make attempts, because otherwise you will not get the answers right. Otherwise, if it's wrong, it's fine. Protein binding, what will occur? Come on. Anyone?
So molecules will be taken up by the protein.
Okay.
So once their binding occurs, then the uptake of the protein drugs will be facilitated.
So it's the other way around. So what happens is it is only the free drug that is active. It is only the free drug that is active. It is only the free drug. So when the drug is injected into the body, it binds to the proteins and it remains unbound. There are two things that occur. Some part will bind and some will be unbound. The one that is unbound is actually the free drug. The one that is unbound is actually the free drug. Clear on this? Clear on this till now? The one that is unbound is the free drug. Huh? It is a free drug that actually works against your organisms. Now, does this mean that if I have very high protein binding, my drug is not going to work at all? The problem also, there is a problem also with this free drug. And what do you think the problem is? This is also the fraction of the drug that will be excreted out. Because more amount will go to the kidney, more amount will go to the liver.
So, but that
You are understanding what I am saying? Sachin, yeah?
so the binding drug may later be available, or like.
Yes, so that is the other part of the story. So, when you have a binded drug, it remains in the tissues for a longer period of time and extends the half-life. It extends the half-life. So, we try to use these principles in our management. For example, okay, now I'll give you an example. Okay, you have you have a patient who's come in with very severe septic shock. Blood pressure is low, pulse rate is fast. You find the patient to be obviously toxic. Clear? Obviously toxic patient. And you have a report saying meropenem sensitive, ertapenem sensitive, imipenem sensitive. You have this report. You have this report saying, and now I'm giving you the protein binding of each of these drugs, where meropenem is 40% protein bound, Ertapenem is 90% protein bound. Which other drug you use and why?
So let's start with meropenem.
Why?
Because
Because
the
it has to act faster.
active drug concentration
More in
Free drug.
Free drug.
The free drug concentration will be so high that will work well. Right? It will work. We want that to work, right? We will have to start with a drug that will have low protein binding. If you start this patient on ertapenem thinking it's a one-day dose, will it work? It's not going to work because what is going to happen is ertapenem is so highly protein bound that the free drug is so less that the patient will die of septic shock. Are you understanding? Huh? Are you understanding? Huh? It's because of high protein binding. This ertapenem will probably not work. Other way around, you have a patient who is not very sick. Patient is not very sick. Patient is at home. Patient is at home, and you decide, okay, let me give him home therapy. I want to give him home therapy, not very sick patient, it's a home therapy. I will want to give her ertapenem. Why? Because it's got a very long
Half-life.
I will give it once a day. Why is it got a very long half-life? Because half of them is going to the tissue and slowly it is coming out. It's remaining bound to the protein and slowly it is coming out. So you're able to extend the half-life of the drug. You're able to extend the half-life of the drug because of the fact that it is extensively protein bound. So I will use this knowledge to my capacity. You're understanding how I'm using all these things to this knowledge to understand this? Clear on protein binding? Clear?
Time dependent.
We have not even gone there till now. Of course, yeah. So
Half-life increasing.
half-life is increasing. That's the only thing that is happening. Half-life means the amount of drug that remains after that particular half-life. That's all. What is your question?
Is time dependence
Time dependent, that's all different. We'll come to that. You understood this protein binding. These are concepts. These concepts I'm going to use to understand what to do. Okay? Protein binding. Then the next concept that we have is called as bioavailability. The next concept called as bioavailability. Now what is this bioavailability concept? This concept is when I give a drug IV, the bioavailability is 100%. When I give the drug IV, the bioavailability is 100%. Of course, this is not something we are worried about in ICU because we are going to give most of drugs IV. But you should know the concept. What the concept is, when I give it orally, how much is it going into the serum? When it's giving orally, kitna absorb ho raha hai? If it is 100% absorbed, if it is 100% absorbed, then that is actually good to convert to an oral in the long term. You're understanding? It is easy to convert to oral for long term. For example, you have drugs like linezolid, you have drugs like levonadifloxacin. You understand? So I'm going to use this. For example, I have a patient who is diagnosed as MRSA. I have put the patient on levonadifloxacin or linezolid. But the IV to oral switch becomes very simple. You understand? The IV to oral switch becomes very simple. So after the patient clinically improves, I will just convert him to oral drug and send him home. You understand? The oral bioavailability. Okay, this is meaning of oral bioavailability, which is very different. For example, posaconazole, an antifungal. I am going to give it IV, but the oral bioavailability is different. It is good, but not very good. So I don't want to convert it. It does not get absorbed properly, and all these problems are occurring. So I don't want to convert it. So bioavailability as a concept you should know. Clear? Clear on this? Clear? Anything further? You understood this? So we have understood volume of distribution. We have understood clearance. We have understood protein binding, and we have understood bioavailability. So these are the 4 concepts of critical care that you should understand when you deal with antibiotics. Okay? We'll take a small break and then we will start with the further concepts if you are okay.